So yesterday was hyperadrenocorticism, which is Cushing's, and then has the different reasons: pituitary dependent, adrenal dependent, or what we call iatrogenic, which means the animal was receiving a treatment that caused the Cushing's, which sometimes happens, which in that situation, it's not necessarily the fault of the pituitary or the adrenal cortex. It's actually caused by the treatment that the animal was getting. Usually, if an animal is on continued steroids, and steroids are a pharmaceutical glucocorticoid, that is what pushes it in. So now we're talking about the flip side, which is hypo or low adrenocorticism, and that is defined as Addison's disease. And this one isn't as common as Cushing's, but it is a deficiency of glucocorticoid or mineralocorticoid secretion by the adrenal cortex. So if you remember, the primary glucocorticoid that the body secretes is cortisol, and cortisol causes that hyperglycemia. It helps mediate inflammation. It helps maintain blood pressure. The mineralocorticoid produced by the adrenal cortex is called aldosterone, and aldosterone typically balances the electrolytes in the body, like sodium, potassium, chloride. And the electrolytes in the body, their job helps to regulate cellular function, acid-base balance, fluid balance in the body. So when everything is in balance via cellular and our fluid balance, our electrolytes are in balance. And aldosterone's primary job helps to regulate the potassium excretion and then sodium retention. And potassium and sodium go together. But again, when you need a balance of sodium and potassium to maintain a normal blood pressure and to maintain normal fluid balance. And this is going to become important when we evaluate an animal for Addison's disease. And kind of the process, how this occurs, it tends to affect more dogs than cats, but can affect cats. And they can be young to middle-aged, okay? So they don't necessarily need to be our middle to older age. It could be young to middle age. It can affect older dogs. So there are some breeds that are predisposed genetically: Great Dane, Portuguese, water dogs, Rottweilers, poodles, Westies, which is, the abbreviation for your West Highland White Terriers, little white Westies, and then Wheaten Terriers. And there tends to be a higher predisposition in females versus males when we're talking about dogs. So it may be seen a little more in a female versus a male, which can have a reflection of hormone levels, but again, and there's a couple forms of Addison's disease. And if we talk about primary versus secondary, so primary Addison's disease, this happens if there's damage or necrosis to the adrenal cortex. Now, if you remember yesterday, I said one of the treatments for Cushing's is we give the medication that causes necrosis of the adrenal cortex. And if you have necrosis of the cortex, now necrosis is when the tissue starts to die off or the tissue is not maintaining its growth. When we give that drug, I said one of the side effects could be you could put the animal into Addison's disease because, that drug is causing necrosis. So, or if there is a natural disease to that adrenal cortex, it could be idiopathic, and which kind of means it could have an immune relationship where the immune system causes a deficiency of this release of these hormones, or iatrogenic, which is exactly that mitotane treatment that we talked about. That means we gave the medication and now we've put the animal into Addison's disease. So if I go backwards, when we give this drug, mitotane, we are going to need to constantly monitor that dog, monitor those glucocorticoid and the mineralocorticoid levels when we're doing that treatment to try and prevent. You try to do a dose where you don't cause complete necrosis and put them into addisons. So that's why animals on those medications need to be monitored during that course of treatment. Now, there's something called secondary Addison's disease. And what happens is you have a deficiency in ACTH, so from the pituitary, and then it causes inadequate release of cortisol. And when you get that insufficiency, and again, this is coming from a deficiency in the pituitary, it affects the cortex. This can be seen sometimes when you have a sudden stop in glucocorticoid medication. So if an animal was on a steroid, and like I told you yesterday, it's very important when animals on steroids, we wean them off. You don't just like give it for 2 weeks and immediately stop. Usually we decrease the dose slowly over an extended period of time, because the way I explained it was when the gland, when you give glucocorticoids, the adrenal cortex is not relying on having to produce glucocorticoids because we're giving it. And then if you abruptly stop, then you're relying 100% back on that gland to produce that glucocorticoid. If we wean the animal, then what happens is that gland should slowly start to produce its own glucocorticoid. And so gradually the medicine wears off, and then the glucocorticoid production increases. And that's the purpose of weaning the medication. And again, you might be in a situation where you have to explain to an owner, why am I weaning this medication? Why can't I just stop? And the problem with owners is the minute their dog looks better, like if their dog stops itching, sometimes they're like, oh, he doesn't need this medicine anymore. And they just stop. Because they think their animal is better. So it's, it's important on us to stress to the owner why we're doing this weaning course rather than an abrupt stop. You can have disease of the pituitary or the hypothalamus, potentially a mass, a tumor, or, a genetic disorder that causes those glands to not release ACTH. There is a treatment in cats, megestrol acetate, that can actually also potentially cause Addison's disease in cats. Now, clinical signs, I didn't have, if I was going to pick a picture of an animal, I would show you a collapsed dog. But I like this picture because basically you have a kidney, you have your adrenal glands, and I have told you the reason the adrenal glands are where they are is if the animal needs to respond in stress, and one of the big things is maintaining blood pressure and blood flow during times of stress. That's why they are located near the aorta and the vena cava, because it can have a direct effect on blood flow. So that's kind of why I picked this pictures, because it's so important. So what are the clinical signs? The problem in Addison's disease versus Cushing's has the very classic pot belly, muscle wasting, PUPD, polyphagic kind of appearance. Like sometimes you can like spot a Cushing's dog a mile away just by kind of looking at it. Addison's is a little bit different. They can have very non-specific lethargy. They might be a little dehydrated. They might have some anorexia and vomiting. They can potentially have some diarrhea with some melena. But, if I look at these first clinical signs, that can point to a plethora of diseases. Like nothing in those clinical signs is like ding, 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 pointing at a disease. So the problem is in early Addison's disease, it's kind of nonspecific, And one thing that I will mention, and this is the hard part of veterinary medicine, especially ER medicine, is that, sometimes owners are like, oh my gosh, my vet wants to do test after test after test. Well, when you have clinical signs like this, animals can present with a variety of diseases with these clinical signs. So sometimes it takes us a few tests to get to the core problem. So initially, the signs are kind of non-specific. You can see some weight loss, and this waxing and waning is really like you have good days and bad days. You might have your dog show some of these signs for a few days, and then they have a good day, and then they have a few bad days, and they have a good day. So it's not like they're consistently going downhill. They can kind of go up and down, feel good, feel bad, and so you may have a few bad days and the owner goes, oh, and then they have a good day and they're like, oh, they're better. And then, oh, they're not, so it's it can be frustrating because, it can do this back and forth kind of presentation. When it tends to hit is there's usually worsening clinical signs, but it was associated with a stressful event. So if your animal was showing these symptoms and then all of a sudden, something stressful happens and they don't respond. But the times that I've seen Addison's disease as an ER tech is what we call an acute crisis, or sometimes it's called an Addisonian crisis. And when this happens, it's definitely when we hit kind of like peak clinical signs and a stressful event. So what happens is the patient can become weak, extremely weak, or collapse. They'll actually potentially fall over. And when the animal comes in, they're typically in hypovolemic shock. Now, hypovolemic is low volume, meaning that typically they have a drop in blood pressure. They don't have adequate blood flow or a blood volume. So you take dehydration on top of a stressful event, bottoms out their blood pressure, and because their blood pressure bottoms out, that's where you get the weakness / collapse. It's kind of like they might, some animals just look kind of like unstable. They maybe don't completely fall over, but they just look like they're very weak. They can be ataxic. And then when they come to us, weak pulse, very low heart rate. And when we look at their gums, they can be pale and have that greater than 2. And again, anytime you have a mucous membrane pale, and anytime you have a CRT that's extended, like greater than 2 seconds, right off the bat, that is inadequate perfusion. The whole reason that you push their gums and see how quick the color comes back is how well is the blood getting to the tissues. So the sooner you guys understand perfusion and what that actually means, is that's like you push the gums, they should immediately get pink within a second or 2. But in these guys, it's usually greater than 2 seconds. They're pale. They tend to be hypothermic, although it doesn't always present as hypothermia. And when you take their blood pressure, they're hypotensive. Now, sometimes you can feel a pulse, and I don't know if I've told you guys this before, but if you can't feel a femoral pulse, it's safe to assume that their mean blood pressure is below 60. So normal mean blood pressure is supposed to be 60 and above to maintain adequate perfusion to the tissues, to the kidneys and to the peripheral tissues. When it drops below a mean of 60, what happens is the body starts to take the blood from the periphery and it starts to centralize blood flow to prioritize the core. So the problem is if you're feeling a femoral artery, that's a peripheral artery. And if you can't feel it, that's an indicator that blood pressure is potentially too low and it's being shifted to another area. So hopefully, usually you're going to do a blood pressure when these patients present. So when we first diagnose, now, if they're coming in with this kind of early clinical signs, sometimes you see increased skin turgor because they're slightly dehydrated. They might be weak and bradycardic, but when you're getting into an Addisonian crisis, they're potentially coming in collapsed, hypothermic, pale, low blood pressure. The best way to describe this, the first time I saw, on ER, this lady rushed in, she had a Shih Tzu, and she was carrying it in the building, and it looked like it was like to be honest, it looked like it was almost dead. Like it's laying in her arms. We rush it back. I can barely feel a pulse. I think the heart rate was 30, which in a Shih Tzu should be up in the hundreds. And we couldn't get a blood pressure. We were trying to get a blood pressure, and heart rate slow, super pale, and the heart rate, being low. And so we start immediately, we get an EKG, we confirm the heart rate's that low. We put in a catheter because, of course, and the first thing we're kind of thinking is, what did this dog get into? So we go talk to the owner. We're like, did he get into a toxin? Did he get into any medication? And she's like, no. She goes, somebody came over, we rang the doorbell, we were going to the door, the dog fell over. So stressful event, worsening of clinical signs. So then the doctor's like, and then all of a sudden, the dog kind of like pops up on the table. It sits there like we're getting ready to give atropine, and it sits up and it pinks up and it's looking at us, and we're like, okay, that's weird. And so, of course, we had drawn our blood and we were starting to get urine. So lab work, the key here is to run electrolytes. Now, normally, the standard lab work is a CBC and a chem. Now, depending on your clinic, we have a separate electrolyte analyzer at VCA. Not every clinic has electrolyte. They should. Some chemistry panels you order will include electrolytes. But if you're doing in-house lab work, you have a CBC machine, you have a chemistry machine. Sometimes you'll have an electrolyte analyzer. And electrolytes are key because if you remember, the mineral corticoids are thrown off in Addison's disease. So usually you're going to be looking for electrolyte abnormalities. So what you tend to see is hyperkalemia, which I have it written down here. Hyperkalemia is elevated potassium, and you tend to have hyponatremia, which is low sodium. So right now, your potassium and sodium are out of balance. And that's a key marker that we find in animals with Addison's disease. You also tend to have a low, if you do a urine, one of the key findings is a low USG, which, remind me what lab class you guys are taking. You're in lab 2. Okay, so you do urine in lab 3. And one of the things we do is a urine specific gravity is, a USG is how concentrated is the urine. And obviously, if it's more concentrated, it's going to be higher. If we have a low USG, it's going to be lower. And part of that low USG is because we have this fluid imbalance due to the electrolytes being out of balance. So, and normally, if you have an animal that's dehydrated, you should have an elevated USG. Normally, when an animal is dehydrated, the body conserves body water and tries to concentrate the urine. If you remember when I talked about the kidney and I talked about ADH, normally in response to dehydration, the body conserves, but we have this imbalance in our fluid compartments, so to speak. So you tend to see a dilute urine. So this is kind of the initial findings. And I should have put on here, take a blood pressure measurement. And usually these animals will have an extremely low blood pressure, bradycardia, extended CRT, and then we have these lab works. Now, when you want to get into specialized lab tests, you can do the same. I haven't written out because in the previous slides, I wrote how to do this test, but you can do an ACTH stim test because if the animal is Addisonian, it's not going to respond to the ACTH stimulation, right? Because if you stimulate the cortex isn't secreting the hormones. So when you stimulate it, you're not going to see a normal response. So your cortisol levels are going to be low when you do this test. The problem is, and what I put here as a note, this test can't always be done. Number one, a lot of times when these animals present, it's indecisive or they present in a crisis. And in an emergency, like our first job with that dog is to stabilize it, put in a catheter, get its blood pressure up, get its heart rate up, get it on a heating pad, get the dog more stable. So ACTH isn't like, boom, we're going to do an ECTH when an animal's crashing. You're going to get your baseline blood work, and you have to stabilize the clinical signs. That's right off the bat. Eventually, and what we recommended after we did the electrolyte levels on that dog that night, we discovered that the electrolyte levels were off. It's probably Addison's disease. Now, what we were going to do, since we're the emergency clinic, we stabilized the dog, and then we were going to send them back to their vet in the morning, and they can go to their vet for ACTH stim testing. So sometimes on an emergency basis, we're not doing an ACTH stim test. Stabilize the patient, get them back to the vet clinic or to a specialist, and then kind of move on. If there is ultrasonography, you can use ultrasound to look at the adrenal gland and look for any, is it normal shape? Something that a term that I didn't use yesterday, it's called echo texture. When you look at an ultrasound, you're using sound waves, the echo and sound. And when you ultrasound an organ, if it's all normal, it sends the sound waves back and it presents as like a uniform texture, a normal color, a normal like textured appearance. And so when you look at it on ultrasound, you're going to look at the texture of the gland and look for, like, does it have the same texture? Is it of normal size? Is it of normal shape? And then the doctor can decide whether they want to aspirate it or not. So this is kind of how we diagnose it. To treat it, it can actually be pretty treatable. So let me look at the bottom here first, okay? Because I like to focus on if they're in a crisis, they've collapsed, they're weak, low blood pressure, you have to treat the presenting concerns. Stabilize the patient, establish fluids, rehydrate, reestablish blood pressure, normalize heart rate, normalize perfusion. Once the patient is stable, we can also give them glucocorticoid treatment. Usually they're going to get IV steroids because, again, if the adrenal cortex isn't producing glucocorticoids, then we have to give them glucocorticoids. So IV steroids like dexamethasone, and then correct electrolyte imbalances. And that's done through fluid therapy. If you remember, IV fluids, wait, you haven't had Tech 4 yet. Sorry, no, you have not had Tech 4. In Tech 4, you get into fluid therapy. IV fluids like LRS or P-Lite, they all have sodium, potassium, chloride. And so we will usually supplement and give electrolytes via IV fluids. So first of all, put them on the proper fluids, on the proper fluid rate to establish electrolytes, establish hydration, normalize heart rate, normalize body temperature. Once you've stabilized a patient in a crisis, then you're going to give the treatment. So if it's chronic Addisons, or you're catching them, I'll say chronic Addisons, or you're catching them early, then they're going to usually, first of all, need a mineral corticoid. There's a medicine called fluorocortisone acetate. It's also known as Florinef. And this is a daily medication that they will give the patient. This is for life. And this will supplement the mineral corticoids. You can also use a medication, it's kind of abbreviated DOCP, but it's called Percotin B, and it's a long-acting supplementation. This is going to be, it's an injection that is given every 3 to 4 weeks. So they would come in for a Percotin injection, which is this long-acting glucocorticoid treatment. And again, the nice thing with that is you give it once every 3 to 4 weeks. They have to come into the clinic and get it. And then what you can consider is giving them some corticosteroid supplement, like send them home with prednisone or prednisolone. And if you add that into the medication, if we know there's going to be a stressful event, like no one can predict somebody's going to ring the doorbell. But if you know they're going to board the dog, which is typically stressful, or you're going to have like a pet sitter in the house, if you're going to change the routine or if there's something that's stressful, the owner can go ahead and supplement and give this prednisone because remember, the adrenal cortex is what's responding in times of stress. So we have to supplement what they're lacking. So these are some treatments that can be beneficial. And again, Cushing's, I feel like if I've looked back to dogs I've seen in my career, I feel like I've seen a fair amount of Cushing's dogs. But the ones that stand out to me were the Addisonian dogs. We had a Great Dane that presented in a crisis. And Great Dane was one of the breeds predisposed. He came in stumbling, could barely walk, same thing, low blood pressure, bradycardic, pale. You know, at first we were like, are you having a cardiac event? And a lot of times when animals present on ER, you know, we're thinking toxin. Are we thinking, you know, got into something, got into the owner's medications, you know, but because a lot of these Addisonian crisis, you know, they do sometimes present like a dog that potentially got into a toxin. So something to think about. And again, I will tell you guys, whenever it comes time to run these tests or use these medications, we're not doing this a lot. We all kind of have to look up and go, okay, we have to draw a sample at this time. Okay, we have to give the medication at this time. So again, until you see enough cases like this, you know, it doesn't become like second nature. Okay, let's talk about one of the more common pancreatic diseases that we see, which is diabetes mellitus. Now, if you remember, I did not put it in this PowerPoint. When I talked about the endocrine system and anatomy, there was diabetes insipidus. Now, when an animal is deficient in ADH, if you remember, the pituitary gland isn't releasing ADH or the hypothalamus isn't producing ADH. And remember, ADH regulates urine production by how much fluid is excreted in the urine. So if they do not have enough ADH, you see the polyuria and the polydipsia, right? That was actually called diabetes insipidus. Diabetes mellitus is from the pancreas, and this is fairly common. What happens is there's B cells in the pancreas, and the cells within the pancreas are supposed to create insulin, and they're supposed to release insulin. So when an animal eats a meal, and when they digest their carbohydrates, and they break them down into sugar, insulin takes the glucose that that's floating in the blood that was absorbed from the meal, and it puts it in the cells. Think about it like a server. I think I've used this analogy before. Insulin's like, here's your glucose, here's your glucose, here's your glucose. And so what insulin does is it lowers blood glucose because it takes glucose from the blood and puts it in the cells. So that's the job of insulin. Number one, lower blood glucose. It puts it into the cells so they can use it. Now, when we have an animal that's deficient or insulin is ineffective in the tissues, so sometimes it's because the pancreas isn't making or releasing insulin, or insulin is ineffective at the tissues. Either way, the insulin is not doing what it's supposed to do. And so what happens is you start to get abnormalities in these carbohydrate, lipid, and protein metabolism. You're going to see a problem in them metabolizing what they need from their diet. And then the number one thing we look for is that we tend to see hyperglycemia, which is, of course, elevated glucose in the blood, or you see glucoseuria. Glucose is the presence of glucose in the urine. Now, important thing to understand. And I don't normally have you guys memorize lab values because when you go into practice, when you get lab values from a machine, they usually give you the range right next to it. But to conceptualize what happens is when glucose starts to get above 300 milligrams per deciliter in the blood, it tends to then spill into the urine. So then it goes from the blood and it goes into the urine. So by the time you have a positive glucose in the urine, you know it's already reached about 300 in the blood. So that's how I want you to understand it. It's like if your glucose is below 300, if it's 200, you're probably going to have a negative urine glucose because you haven't reached enough in the blood for it to show up in the urine. But once you've reached a level in the blood, then what it does is it starts to spill into the urine, and then glucose. So glucoseuria is pretty significant because we know if it's in the urine, it's up here. Now, a lot of times when we're evaluating these patients, you're going to be doing blood and urine at the same time, and you might get those results. But if you say you got the urinalysis first, say you got your dipstick, and you're like, wow, there's glucose, I'm going to bet by the time you do your blood work, that glucose level is going to be pretty darn high. So that's the connection to hyperglycemia and glucoseuria. So you need to know what those mean. There are definite breeds that's, scream diabetes. If I was playing a game like Family Feud and they're like, #1 breed for diabetes, I'd hit that table and go, schnauzers, schnauzers. I feel like I could probably list 100 patients I saw over the years. I'm just kidding. But schnauzers tend to have definitely predisposed poodles. We don't see a lot of Keeshonds anymore, but you can have Keeshonds, Cairn Terriers, Cocker Spaniels. My practice in Chicago, I feel like we saw a bazillion Cocker Spaniels that were diabetic, but and Beagles. And there seems to be a higher prevalence in neutered males. Now, I wouldn't say don't neuter your dog because it might become diabetic. I would never say that because there's definitely huge advantages to neutering your males. So I wouldn't be like, don't neuter them, they might get diabetes. But there seems to be maybe a little bit more of a prevalence. There are a couple different types of diabetes. So there's type 1 and type 2. And the ones I feel like I saw more in practice were the type 1. Now in people, like for example, my stepdad has type 2 diabetes. So he can get an elevated blood sugar, but a lot of times all he has to do is watch what he eats and exercise a little more and don't eat ice cream at night, and he takes some pills, but he can kind of manage it just much. And this is because type 2 is called non-insulin dependent. They don't have to take insulin with type 2 diabetes. So the thing with type 2 is the pancreas is secreting insulin, but maybe not normal amounts of insulin, or there is peripheral resistance. There's resistance in the tissues to insulin. Now in animals, this is a little more common in cats than dogs. And cats can go into remission, like it can go away. And these guys usually do not get the ketoacidosis. I'm going to talk about diabetes ketoacidosis, and very rarely does type 2 go into that ketoacidosis. Now, type 1 is what I tend to think of as a more traditional diabetic, is they are insulin dependent. And that's IDDM versus NIDDM. So this happens because there can be B-cell destruction, damage to the pancreas, genetic, inherited issues, there's decreased insulin production enough where they are diabetic. Amyloidosis in cats, and this can happen sometimes after they've had damage to the pancreas or they haven't eaten for several days, and it kind of throws them into a type 1 diabetes. Now, type 1 diabetes is bad enough, but what we don't want to do is we don't want to get into what's called a ketoacidosis, a diabetic ketoacidosis, because this happens we tend to see this when you have very severe unregulated diabetes. So sometimes the owners haven't picked up on the early signs of diabetes and they've let the dog go. Or if you have a recently diagnosed diabetic and you're having a hard time getting them on insulin and regulating them. So sometimes you have a very stubborn diabetes case that we can't get regulated. And regulated means we're going to give them insulin and we're going to find a dose that's going to maintain that patient. So that's what regulation. Okay. Now, ketoacidosis, they come in very, very, very sick. They can die from diabetic ketoacidosis. What happens is, think of it this way. It's the best way I can describe it. When an animal eats and they absorb the diet, they absorb the food, and then glucose enters the bloodstream. Now, the cells are like, where's the glucose? If the insulin isn't putting the glucose into the cells, the body thinks that the body has not eaten. Even though the animal, because sometimes ketoacidotic animals are eating. Sometimes we see it when diabetics have gone several days without eating. Say they've been vomiting for several days, the owner can't get them to eat, but sometimes animals are eating, but because the body has not recognized that glucose is there and the insulin doesn't put the glucose in the cells, how is the body going to access glucose? It's going to break down itself. So what happens is the body doesn't recognize that there's glucose in the blood. Insulin doesn't move it into the cells, and it starts burning fatty acids. So it starts burning its own fatty acids as fuel to try and access. But the problem is when the body breaks down or burns up fatty acids, that creates a compound called a ketone body or ketones. The more rapid that this happens, the higher the levels of ketones get. And when the animal gets too many ketones, it creates what's called a metabolic acidosis. And if you remember, the body likes to be in hemostasis, right? The body wants to be at base. When you have too many ketones being produced, you make the blood acidotic. And then acidosis affects all the cells of the body. And then they get very, very sick. So these dogs can come in weak, lethargic, collapsed, vomiting, and like I said, ketoacidosis is an emergency. They need to get in, and sometimes, like, we had a few cases, it took us almost a week to get, first of all, because when an animal presents in a crisis, you have to stabilize. So we have to stop the vomiting, we have to give fluids, we have to get them more aware out of unconsciousness, and then we have to try and start them on insulin and regulate them. And that can be quite a process to stabilize the patient and then regulate them. So it kind of depends at what stage, but some diabetes symptoms, and sometimes, again, these are kind of indescript. Polyuria and polydipsia, and I think I told you guys when I've talked about PUPD, it's a symptom of about 50 diseases. So just because they're PUPD, but the problem is in diabetes, when they have elevated blood sugar, it makes them feel thirsty. Actually, elevated sugar can actually dehydrate them because sugar pulls to it, okay? It can pull from the tissues. Blood sugar pulls fluid in. And then what happens is they feel very thirsty. And the more they drink, the more they urinate. So you tend to get this PUPD. A lot of these dogs will form cataracts. Now, cataracts aren't typically acute. Like one day your dog has normalized, the next day have cataracts. But you'll see in a lot of diabetics, if you look in their eyes, they've kind of got this white shimmery appearance, which can eventually lead to blindness. So they may have this disruption in sight from these cataracts. And they tend to have a history of recent UTIs, urinary tract infections. Well, the problem is when you have elevated blood glucose, and also if some of that glucose potentially also makes it into the urine, bacteria like that and proliferate. So any elevation in sugar tends to put them at a risk for or recent infections, skin infections, scooting near their vulva and having excess discharge. But UTIs, urinary tract infections, are a really common accompanying clinical sign. So recent UTI, cloudy eyes, PUPD, except that they're losing weight, so they tend to start to lose a little bit of weight. Now, when they're in what's called ketoacidosis, then what happens is we start to see they've got the vomiting and diarrhea, and they're usually very dehydrated. And all of that tends to make them lethargic, because if they're vomiting and having diarrhea, and even if they're eating, remember I said they might be trying to eat, but the body's not recognizing the glucose, so it's going to break down the stores. Now, they can get into tachypnea. Now, tachypnea is a rapid respiratory rate, and they just kind of feel uncomfortable, and it makes them, tachypnea and panting are very close. Usually tachypnea you can count and panting you can't. When we get into later ketoacidosis, when we're getting further in, they can be in like a stupor. Now, a stupor is when they're like, well, think about a drunken stupor. If you're like stumbling and walking and bumping into things, all the way to a coma. If you can find them almost unconscious. And one interesting thing that might be picked up on is they have an acetone smell to their breath, because when they have these buildup of ketones, ketotic animals get this acetone smell. So their breath might smell different. Maybe the owner says that, or you might notice when you do the physical exam, you're like, I can actually smell these excess ketones. And I'm not super good at that. Sometimes I think my sense of smell is not super great, but definitely I've had a few patients where I'm like, yep, I can smell that acetone smell, and that's and cats, interestingly enough, can present, it's called plantigrade posture, but instead of walking on their paws, like just their paw pads, they'll actually kind of bend their feet back, and they're walking on that flat part of their hock. They're actually kind of walking in an interesting position. So how do we diagnose? Well, obviously, the history and physical exam are going to be kind of glaring. Obviously, PUPD, vomiting and diarrhea, and also potentially urinating in the house, especially if you have if you have a dog that's well potty trained, and all of a sudden they're peeing in the house. They can do that for a couple of reasons. One, they have a UTI, or two, they are drinking so much they have a hard time holding it. Blood work is going to be key to, you tend to first of all have the hyperglycemia is key. When you do the glucose, and it can be as high. Now, normal glucose is 80 to 120. So when you start getting upwards of like 200, 300, obviously that's super, super high. They can, remember, any animal that is dehydrated can have an elevated PCV. It's called hemoconcentration. And potentially ALP or ALT elevation. When an animal is mobilizing fatty acids, it can cause what's called hepatic lipidosis, which is a buildup of, it's a fatty liver. And because they're breaking down fats, it can cause this hepatic lipidosis, which could affect your liver enzymes. And then hypercholesteremia. The Na, your Na is sodium, Cl is chloride, K is potassium. Sometimes those electrolytes are actually decreased because they're drinking so much. So they actually dilute out their electrolytes. And then lipase can be elevated. Now, amylase and lipase are two enzymes that come from the pancreas, And sometimes animals that are diabetic, they'll have a pancreatitis or an inflammation of the pancreas that can cause that elevation. Usually you're going to do a urinalysis for sure with these patients. And obviously the number one thing is there glucose in the urine? Because again, that gives us an idea of how they're managing their glucose. Obviously, it's a little better for the patient if it's positive in the blood and negative in the urine. But if it's elevated in the blood and the urine, we have a significant hyperglycemic patient. And sometimes when you do the sediment on the urine, you can have proteinuria and white blood cells. Now, an animal doesn't usually have protein in their urine, but if they have cells in their urine, like red blood cells and white blood cells, then you tend to see that protein positive. And then all of your urine sticks that you do this to have a ketone that you can look at. Let me skip ahead and show you. I know we're almost done, but I'm going to go through the rest of these on Monday. But here's an example. Since you guys haven't done urinalysis yet, just hang tight. Hopefully you don't have to take off. This is what, when you do a dipstick on a urine, and the little squares have different colors. Now, if you put urine on a stick and it's negative, it's going to be this light green. And then it can change these colors. And this gives you an idea of the level of glucose based on the color. And then ketones can also be traced. Now, ideally, in a diabetic patient, you'd like both of these to be negative, but it's common to have glucose positive, especially when glucose is high in the blood. Hopefully you get negative ketones, because if they're making ketones, then we're getting into that ketoacidosis. So this gives you an idea. Usually when you do a urine, there's a paper that you fill out and you mark these colors and you mark these values. So, okay, and since it's time to end, I will stop there. Do you have any questions based on what I talked about today?